In the last 2 years or so, we have experienced different waves of COVID transmission due to the emergence of various variants. However, the clinical presentation remains largely similar for most patients. In the initial phase of the infection, the viral replication is at the highest level. The majority of patients would experience mild symptoms, and most of them would recover spontaneously. However, around 10 to 15% of people might progress to severe disease, and we have now learned that this phase is more likely due to hyperinflammatory response. In this talk, we will review the short but very exciting history of research in therapy for COVID disease. In the initial phase of the pandemic in early 2020, most countries around the world have struggled to manage people who are hospitalized with COVID because of very severe illness. And during that phase of the pandemic, most of the research targeted on the treatment of these severe cases. And in the initial phase, people looked at antivirals, and most of them are repurposed drugs for treatment of other viral infections. Later on, as we learned about the pathogenesis of the disease more, we understand that inflammation and immune dysregulation plays a very important role in severe illness, and more research was then directed to the use of immunomodulatory drugs. And subsequently, when the pandemic is more well controlled in most parts of the world, and because of learning the pathogenesis, knowing that the viral replication phase is highest at the initial cause of illness, people started to look at early use of antivirals or other therapy to prevent disease progression. And of course, we have now known that long COVID is a very important disease entity for some people after COVID infection. And now some studies are focusing on the management of long COVID. In this talk, I will focus on the first 3 parts on the treatment research in the last 2 years, and will share experience from Hong Kong as well. So in the last 2 years, with the emergence of new evidence for therapy for COVID, the treatment guidelines in Hong Kong has also changed quite frequently, especially in the last 6 months. So in the first part, I'll talk about antiviral treatment for severe disease. Although different antivirals have been tested in various trials for the treatment of severe disease in hospitalized patients, currently most guidelines across the world included only intravenous remdesivir as the recommended treatment for people in this category. So you can see from this table that most of the treatment guidelines recommend the use of intravenous remdesivir for people who are hospitalized for COVID disease who require some form of supplemental oxygen. And the evidence is strongest for those on low flow oxygen, high flow nasal cannula, and also non-invasive ventilation. However, you can see that most of the guidelines did not have specific recommendations for those who are mechanically ventilated. In some of the guidelines, for example, those from Hong Kong and UK, we did have a remark on the stage of infection, because we understand that viral replication should be greatest during the first week or so. Therefore, people who presented late in the course of disease, especially those with lower viral load, might not benefit from this treatment. And these guidelines obviously were based on published randomized controlled trials. So these are examples of some of the larger trials, the Solidarity trial from WHO and ACTT1 from the US. And you can see that from both trials in the final analysis, there were survival benefits and also improvement in time to recovery, especially in the subgroup of patients requiring supplemental oxygen. And there were also retrospective cohort studies looking at real-world evidence for the use of remdesivir in this group of hospitalized patients with severe disease. For example, this large cohort study from the US looked at people who were receiving remdesivir and matched to those who did not receive the drug. And you can see from the table on the left-hand side that the mortality rate was significantly lower for the group who did receive the drug. And in the figures on the right, we can see that in patients who are receiving supplemental oxygen, there was survival benefit. But even in the group receiving mechanical ventilation, there was a benefit as well. So how should we actually interpret these data and apply to our clinical setting? This post hoc analysis from the ACTT1 trial might give us some clue. So this trial looked at all the participants in this ACTT1 trial and looked at different clinical or laboratory parameters to derive a risk profile score for prediction of mortality. So other than just looking at the oxygen requirement at the time of hospitalization, they also looked at other biochemical laboratory parameters. And you can see the ROC curves on the left-hand side that this risk profile score is actually performs better than just looking at the oxygen requirement in prediction of death or progression to intubation. And on the right-hand side, they compared the survival outcomes between patients on remdesivir and those who did not receive remdesivir according to the different risk scores and also according to the different levels of oxygen requirement. And you can see that on the left-hand side, those who are predicted to have a higher risk of death or mechanical ventilation by the risk profile, those in the categorized in the high-risk group on the top of the diagram, you can show that those patients actually have the largest difference when they are given or not given treatment. Therefore, I think that although the disease course was quite similar among different variants and in different populations, there are actually some differences within a certain host that might help us to predict the disease course and disease severity. And this form of personalized care, making more individualized decision choices for treatment, might be the way to go for patients who are hospitalized with severe disease in guiding us which population might benefit most from these antiviral therapy. So secondly, we will move on to talk about research in immunomodulatory therapy for severe disease. So very on in the pandemic, many groups of researchers have shown that the inflammatory response is actually a very important part in the pathogenesis for people who progress to severe disease. So this is an example of one of the studies from our group. We looked at a longitudinal profiling of the peripheral cytokine profiles for patients admitted to our hospital in the mild, moderate, and also severe categories. And we looked at the early phase of cytokines in the first week and also the cytokine profile in the latter part of the course of illness. And similar to many other studies, we have shown that the pro-inflammatory Th1 helper and also the ARDS-associated cytokines, including interleukin-6, were increased progressively in patients with severe and critical disease. And moreover, some of the parameters, for example, MCP1, actually correlated with disease severity in the critical disease group. For example, they correlated with the length of duration requiring mechanical ventilation. And of course, the immunopathogenesis involved in COVID was actually very complex. So this review article from Nature Medicine earlier this year actually is a very good review on the underlying pathogenesis and also summarized the existing therapeutics in terms of immune modulation in people with severe disease. So after the infection, we know that the virus will attach to the ACE2 receptors in various cells in our body, and also with the help of the transmembrane serine protease, they would enter the cells. And after this trigger, that would cause a lot of disturbance in our innate immune system, causing the macrophages and neutrophils to secrete various pro-inflammatory cytokines, causing T-cell activation and also lymphopenia. And with these mediator functions, that would actually cause disease or pathogenesis in various organs in our body. And of course, the lungs are the major site of disease in severe critical illness. And this can cause direct lung injury because of these inflammatory these levels of inflammation, and also thromboembolic diseases because of coagulopathy associated with COVID infection. Therefore, the treatment of severe COVID, of course, would involve therapeutics targeting these inflammatory and coagulation pathways. So in Hong Kong, as in many parts of the world, our treatment guidelines involve the use of dexamethasone in people who are requiring supplemental oxygen, non-invasive ventilation, or intubation. And dexamethasone was actually the first drug proven in a randomized trial, in the recovery trial, to improve survival in people with severe COVID. And at that time, it actually brought a lot of hope to patients and also physicians treating COVID. Subsequently, there are other immunomodulatory agents, including the interleukin-6 inhibitors and also the JAK inhibitors, etc. And these have been shown in randomized trials that would improve survival in patients with severe COVID. And these drugs are available in Hong Kong, and these are also in our treatment guidelines for people with severe disease. More recently, we expected to see results of more trials comparing these different drugs. In Hong Kong, when we do have the availability of different immunomodulatory agents, some of our colleagues would ask which drug to give for a particular patient. So we hope that with the release of more of these comparative trials, head-to-head comparison of different immunomodulatory agents would guide our treatment in the future. This is an example from a recent publication from Lancet Respiratory Medicine, comparing use of dexamethasone versus the JAK inhibitor baricitinib in patients with requiring supplemental oxygen. And so you can see that baricitinib performed non-inferiorly compared to dexamethasone. In this trial, there was more treatment-associated adverse effects associated with dexamethasone. And if you look at the supplementary materials, you would find that most of these adverse events were due to either lymphopenia or hyperglycemia. So evidence such as these from these types of trials would enable us to have a better choice of treatment when we do have options. And one point of caution, in Asia, many countries in Asia, hepatitis B chronic infection is still quite a significant and prevalent problem. And therefore, when we are using these immunosuppressive agents for the treatment of COVID, be it a very short course, we should be aware of various forms of infections, for example, the reactivation of hepatitis B virus. So our hepatologist group from Chinese University have reviewed evidence on the risk of reactivation of hepatitis B in patients with COVID or other disease causes who are using immunosuppressive therapy with doses and duration similar to what we have been giving to our COVID patients. So although the numbers are not huge, especially the data directly derived from the COVID cohorts, there is some evidence that people who had chronic hepatitis B and put on antiviral suppressive therapy have a much lower risk of reactivation of hepatitis B. Therefore, in this part of the world where we are still having quite a number of people with hepatitis B, screening for hepatitis B and giving appropriate antiviral therapy might be something we have to be aware of when we are treating patients with severe COVID. So next, we will talk about the more recent development in therapeutics research in COVID. So this is the treatment given to patients who present very early in the disease course, usually with mild symptoms treated in the outpatient setting. However, we would like to give them something that's effective to prevent the progression to severe disease, thereby reducing hospitalization and even death. So at this juncture, there are already several options that have been proven in randomized trial that would benefit this particular group of patients. So all these drugs listed in the table have been tested in randomized trial with very similar study design and study population. So these trials were performed in participants presenting with a mild disease in the early phase of infection, usually within 5 to 7 days of symptom onset, and they do have one or more risk factors for progression to severe disease, and they were randomized to either one of these drugs versus placebo. And you can see that the first three drugs in the table are the antivirals, whereas the last column represents one of the study of the monoclonal antibodies. So I'll talk about monoclonal antibodies in the latter part of this talk. And for the antivirals, we can see that each of them have different pros and cons. For immunomodulatory and remdesivir, obviously the effective efficacy in terms of the relative risk reduction and progression to severe disease was higher. And however, remdesivir has to be given as an intravenous dose over a course of 3 days, and that would actually give a lot of hindrance in the outpatient treatment of COVID infection. But of course, its high efficacy is experience in use in pregnancy, and also the lack of drug interactions are some of its advantages. And between the two oral drugs, immunomodulatory has higher efficacy, and ritonavir, part of the regimen, is probably safe in pregnancy, as with our experience with HIV infection. And however, they cannot be used in patients with severe chronic kidney insufficiency, and also the lots of drug-drug interactions is a major problem, limiting its use in people, especially those with chronic diseases and also use of chronic medications. Molnupiravir has the advantage of a lack of drug interactions, and also is used in patients with liver or chronic liver or kidney diseases. But of course, the efficacy was lower as shown in the randomized trials. And these figures show the results of the MOVE-OUT trial and the EPIC-HR trial for these two drugs, and you can see that both drugs have efficacy in reducing hospitalization and death. However, the characteristics of the participants for these trials might not represent the patients that we are now seeing that present to us in Hong Kong or in other parts of the world, for some of these reasons. Most of these patients are actually relatively young, whereas in our population, and especially those who do present to the healthcare system, probably are older and also have a wider range of comorbidities. In both of these trials, the most common risk factor for disease progression was obesity, and that is probably not the major risk factor for populations in Hong Kong or other parts of Asia. And both of these trials were performed in 2021, and circulating variant was Delta or the earlier variants, and therefore we are not quite sure whether the same efficacy could be seen in the current Omicron wave across the world. And more importantly, at that time in 2021, most of the population were not fully vaccinated, and the participants were actually not vaccinated, as this is an exclusion criteria for participation in this trial. Therefore, whether these drugs worked similarly effective in the real world with patients who are older, with more different forms of comorbidities, infected by Omicron, and also either partially or fully vaccinated, this is actually quite uncertain. In terms of the activity against variants, in vitro data did show that the currently available antivirals actually have similar activity across the different variants. And in terms of the subvariants for Omicron, this publication from Japan also showed that using a hamster model, the different antivirals, including molnupiravir and also the 2 protease inhibitors, did reduce the viral replication, especially in the lungs in the hamster model infected by BA2 subvariant. So in Hong Kong, after we have these 2 drugs available from the end of February and early March, we have made local recommendations for the use of these oral antivirals. So anyone older than 60 years old or severely immunocompromised are eligible to receive the drug. For those under the age of 60, they can also receive the drug if they have the high-risk factors as shown here, and also with incomplete vaccination. And of course, they should present with mild symptoms and also within 5 days of symptom onset. So in Hong Kong, there were more than 20 designated outpatient clinics for management of COVID. Therefore, we reviewed the data of the attendees of these COVID clinics in the period of February to March to look at the primary endpoint of hospitalization and to compare this endpoint between people who were prescribed the drugs and those who did not. And we balanced the 2 different groups by propensity score weighting. And from this table, you can see that those who did receive the drugs were older and also have more comorbidities, particularly diabetes and also cardiovascular disease. And around less than half of the population who received the drugs were vaccinated, received complete vaccination, which means either 2 doses of BioNTech or 3 doses of CoronaVac at the time of the study period. And after propensity score weighting on the right-hand side of the table, you can see that the 3 groups with no treatment, molnupiravir or nirmatrelvir treatments, were matched for their demographics and also other clinical characteristics, and also the time of presentation during the course of the 5th wave in Hong Kong. And on the left-hand side of this table, the primary endpoint was the time to hospitalization. And comparing to the group who did not receive any oral antiviral drugs, we could not show a benefit for molnupiravir, whereas for nirmatrelvir, it significantly reduced the risk of hospitalization by around 20%. And currently, there are a few other publications, either as preprints or in medical journals, that have also looked at real-world evidence of the use of these oral antivirals. And the results were quite similar, showing a reduction in hospitalization, especially for nirmatrelvir. And also, these studies identify some groups of people, especially those who are older and also with comorbidities. And even with vaccination, they do benefit from the drugs. So lastly, on the use of monoclonal antibodies. So different from the use of oral antivirals, many of these monoclonal antibodies did have the problem of developing resistance to the new variants and subvariants. However, these monoclonal antibodies were shown in previous trials, similar to the use of antivirals, oral antivirals in the early phase of disease to prevent hospitalization. And in this real-world evidence, we can even see that the earlier the use of monoclonal antibody, the greater the effectiveness. And at the moment, when the Omicron subvariants are circulating, many of these commercially available monoclonal antibodies are no longer effective. In Hong Kong, the currently available monoclonal antibody that's effective to Omicron was the Infectious. And we are prescribing this drug as a pre-exposure prophylaxis to people at high risk of severe disease and also who are more high chance of not able to develop immunity even with vaccination. And just briefly on the last part of this talk, the use of monoclonal antibodies might also have a role in people with who are very severely immunocompromised because they fail to develop immunity to vaccination or natural infection, and they are prone to have prolonged courses of viral shedding and prolonged hospital stay and severe disease. There are data in the real world using either these monoclonal antibodies or convalescent plasma in this group of severely immunocompromised patients in treating severe disease to shorten the disease course or even with survival benefits. So thanks very much for the chance of reviewing the history of research in therapeutics for treatment of COVID in the last 2 years. And fortunately, we have more effective therapeutics now than 2 years ago for treating the different stages of COVID disease. And I'm sure that with more research, we will be able to adopt a more individualized, personalized approach in the treatment for our patients. Thank you very much.